Pharmacy prep, opiates, a complete review, and opiates introduction. Opiates are a class of drugs naturally found in the opium poppy plants. Originally, it was found from the poppy plants. However, now you have a semisynthetic and synthetic opiates. And primarily, they work in the brain and also peripheral nervous system, and they produce variety of effects, especially known for pain relief. Well, the common uses of opiates are typically used for managing moderate to severe pain, such as pain from surgery, injuries, or cancer. Well, opiates can be categorized into three categories, such as natural opiates, semisynthetic, and then synthetic opiates. The natural opiates are currently available are codeine. Generally, codeine comes in many generic products, comes as a codeine sulfate salt, and the morphine. Morphine brand is MS Contin, which is the most popular one, and also there are other brands for morphine available, and morphine sulfate. The semisynthetic are that means modified from the natural opioid, a partial modification that's called semisynthetic. And those are hydromorphone, the brand is dilaudid, hydrocodone, and oxycodone, the brand is Oxycontin. Well, recently there are more synthetic opiates are available, like fentanyl, duragesic brand. That is one of the most potent opioid of all opiates currently prescribed. Then meperidine, demerol, methadone, methadose. Methadone commonly used for opioid withdrawal treatment, also known as opioid maintenance treatment. And then tramadol brand is Ultram. Well, there are opioid agonist and antagonist. Like previously, what we saw, like codeine, morphine, those are opioid agonist. Here it is opioid agonist and antagonist, especially buprenorphine, which is primarily partial agonist, which comes in brand Subutex and also Bitran. Well, buprenorphine famously comes with the combination with naloxone, and the brand is Suboxone. Well, opiates are also comes with the combination with other non-opiate drugs like primarily acetaminophen and also acetyl salicylic acid. Here, some of those combination opiates are acetaminophen and codeine comes in Tylenol with codeine. Number three, which consists of 30 milligrams of codeine and 325 milligrams of acetaminophen and 15 milligram of caffeine. And there is a Tylenol with codeine number 4, Tylenol 4, which contains 60 milligram of codeine and 325 milligram of acetaminophen. Other combos are hydrocodone with acetaminophen, comes with the brand Vicodin or Narco, and then oxycodone, and acetaminophen comes with the brand Percocet or Endosets, and then tramadol acetaminophen brand combination that is a Ultraset. These are some of the combination with non-opiate product that are pretty popular for prescriptions. Here, some of the opiate that comes in the top 200 drugs, such as morphine and oxycodone, tramadol, and also these monographs can be found in details in Asterix online platform. You can find details of this monograph. To get to those tramadol, and all other monographs in detail and their key points, please do subscribe Asterix Drug Monograph Drug Information Resource Platform. All right, so let's talk about the dosage and administration of opioids. Opiates are comes in various dosage forms, right from topical to oral, and also sublingual and injections. Among them, the popular ones are fentanyl. Fentanyl comes in buccal, sublingual, transdermal, epidural, IM, IV, and also the hydrocodone comes as a syrup, and also codeine comes in syrup. Often those syrups are used for cough suppressant. And then other ones are preparation for hydromorphones. Those are comes in immediate release preparations and control release preparations and injections. Methadones commonly used for opioid withdrawal management or treat methadone maintenance therapy and generally comes in oral and also solutions. For those methadone maintenance treatment, methadone oral solution is given along with the juices such as orange juice, etc. And then oxycodone, which is popularly known for oral tablets and also control release tablets and injection as well. So dose ranges are given here. So we'll talk about the dosages in next slides. So other dosage forms that are popular ones are meperidine, which comes as injections and oral, and of course morphine, which is comes as injections, oral, and also subcutaneous rectal preparation. Oxycodone primarily comes in oral dosage form, and tramadol also comes in oral and injections. So there is a morphine equivalent dose. So one converting from one morphine dose to other morphine dose have the used by morphine equivalent dose method. So what exactly that morphine equivalent dose means? For example, morphine and the IM morphine or IV morphine 10 milligram or oral morphine 30 milligram, which is equals to hydromorphone 6 milligram. And also 30 milligrams of oral morphine equals 15 to 20 milligram of oxycodone. And then especially 200 milligram of codeine is equals to 30 milligrams of oral morphine, whereas 300 milligram of meperidine equals to 30 milligrams of morphine. So among this, you could see the most potent here in this given oral opioids, that is a hydromorphone, which is 30 milligrams of morphine equals 6 milligram. That means when you're switching from morphine to hydromorphone, so if patient is taking 30 milligram of morphine, then equivalent of hydromorphone is 6 milligram. So that is only applies to around the clock dosing or single intermittent dosing. And then when you're switching, especially switching, calculating the opiate dose, generally this method applies to high dosages of opiates. High dosages refers to most references that recommend 90 milligram daily morphine dose. Oral morphine dose or more than that is considered as a higher dose of opiates. So when you're calculating daily opioid dose, first step is calculate the morphine equivalent dose of the new opioid. First step is calculate 24 hours total daily dose of opioid and then calculate equivalent dose and reduce new opioid dose 30 to 50% if current opioid dose is high, 90 milligrams per day. So 30 to 50% reduction dose for the new opioid is depends on the prescriber's choice. And then or reduce the new opioid dose 30 to 40% if current opioid is less than 90 milligrams. So over 90 milligram is 30 to 50%. If it is less than 90 milligram, 30 to 40%. Those are recommended for opiates morphine equivalent dose switching. Let's talk about the clinical uses. The clinical uses of opiates are primarily for severe, moderate to severe pain, and generally comes with the from surgical pains or severe injuries or cancers. However, also used for cough suppression and diarrhea management. Mainly here you could see the morphine primarily used for pain relief, not used for cough suppression or diarrhea. Codeine is used for moderate to severe pain, but generally it is not that strong enough to be a effective for cancer and palliative care. However, combination can be used. Whereas codeine typical use is can be also used as a cough suppressant, which is not morphine is not used. Whereas fentanyl is mainly used for pain relief, post surgeries, cancer. However, fentanyl is not used for naive patient. Um, as per clinical practice guidelines, fentanyl is recommended for those patients who take at least 60 milligrams of morphine equivalent dose. Then only you can switch to the fentanyl. Hydrocodone also can be used for cough, whereas other medications here, oxycodone, methadone, primarily used for pain after surgeries and cancer pains. Let's talk about warnings and precautions. There are serious warning and precautions that includes these opiates are known for addiction, abuse, misuse. Abuse can be addictive, subject to abuse and misuse. So therefore, this require precautions for those. And serious concern would be life-threatening respiratory depression. Opioid can be deadly and can cause severe fatal respiratory depression. And also, accidental ingestion, one dose of opioid, especially in children, can result into fatal overdose. So that means that is required serious precaution. Neonatal opioid withdrawal syndrome, prolonged use of opioid during pregnancy can result into neonatal opioid withdrawal syndrome. So generally, it is not preferred or not less likely used during pregnancy. There's a long list of contraindications for opioids. Let's talk about what is exactly not used for opioids. Hypersensitive to any opioid, avoid other opioids, and especially asthma and upper respiratory obstruction. Special that can cause opioid can cause severe respiratory depression, and then pregnancy, especially risk of neonatal opioid withdrawal syndrome, and then concurrent use of MAO inhibitors completely contraindicated, at least for 14 days, have to be separated from MAO inhibitors. And then known to cause severe CNS depression with alcohol use and also can increase the risk of respiratory depression. And especially gastrointestinal obstructions such as opioid can exacerbate condition like paralytic ileus. So therefore, any gastrointestinal condition that are associated with the gastrointestinal obstruction, then opioids are contraindicated. So opioids naive patients such as first timers should avoid using buprenorphine, naloxone, fentanyl, and also oxycodone above the 40 milligram. Oxycodone, naloxone control release tablets should be avoided or contraindicated in opioid first time users. And then opioid dependent patient, opioid agonist antagonist can precipitate withdrawal symptoms such as buprenorphine with combination with naloxone. If you are using them on opioid dependent patient, they may experience withdrawal symptom because of there is a naloxone um, in those preparation that cause antagonistic effect on opioid receptors. Well, next one is opioid dependent patient, also can precipitate for withdrawal syndrome. CNS depression can be serious, especially in head injuries and elevated CSF pressure, acute appendicitis, pancreatitis, and seizure disorders. Myasthenia gravis due to increased risk of respiratory depression if muscle rigidity occurs. And substance use disorders, opiates are not recommended for chronic non-cancer pain treatments. Other contraindications include circulatory shock. Opiate can cause vasodilation, severe hepatic impairment, especially with buprenorphine and buprenorphine, naloxone, oxycodone, naloxone, tapentadol, tramadol. Those are contraindicated in severe hepatic or renal liver problems, and also severe renal impairment. Oxycodone, naloxone, tapentadol are contraindicated, and codeine is contraindicated in postoperative management of pain children in less than 18-year age and following tonsillectomy. Adenotectomy is also contraindicated. Let's talk about mechanism of action for the opioid. That has a exciting information. So to understand that, first we have to understand the pain pathways. So let me break down pain pathways. So in the pain pathways, first point is here tissue injuries. So that pain pathways can be divided into four steps. First step is the transduction. Transduction is at the site of injury when transduction path takes place, where the pain transmitted into electrical signals through the delta and C fibers. And then second step is it does act modulation on the spinal cord and then goes to the ascending pathway to the brain, and also information passed to the thalamus, and that process known as transmission. So once the pain message are transmitted to the thalamus, thalamus transmit those to the somatosensory cortex, and pain is felt in the brain. So, and that perception is the fourth step of this process. So this process is basically, obviously, once pain perception is felt, and then the descending pathways of um, from thalamus begins, and then release activation of uh, neurotransmitters of pain, opiate neurotransmitters takes place in the substantia, the latinosa sites. So let's talk about details of the modulation step. So first, sensory neurons senses the pain perception, and then they act and release those various substances such as neurotransmitters, substance P and glutamate, and then also CGRPs. They are released from those neurotransmitters and then passed on to they activate the secondary neurons which contain neuro receptors like NK1 receptors. Substance P bind to the NK1 receptors, and then glutamates have NMDA receptors, and then AMPA receptors. So then further, uh, ascending pathways in pass on information passes to the brain, and from the brain, then descending pathway begins, and they activate the neurons which contain opioid neurotransmitters such as enkephalins, dynorphins, and endorphins. And those neurotransmitters are known as peptide type of opioid neurotransmitters. And those they bind to those opioid receptors like mu and kappa and delta receptors. And that way they slow down the pain that is activated by substance P and glutamate, and which is coming from sensory neurons. To understand better this process, we have to understand more about specific role of opiates here. So, for example, opiate neurotransmitters and receptors. The opiates are um, the neurotransmitters. They are primarily activated once pain message received into the brain in the central nervous system. Those pain neurotransmitters are activated and released in the mainly primary site as thalamus and also periaqueductal gray areas, and those areas those neurotransmitters are released like endorphins and those peptide type of opioid neurotransmitters. They release and they bind to the primarily they bind to the mu receptors, and then enkephalin primarily bind to the delta receptors, and dynorphins primarily bind to the Kappa receptors. And those receptors, here the mnemonic for those, mnemonic for opioid receptor and their primary ligands. My dolphin's kiss. So my M mu receptors or morphine or binds endorphin bind to the mu receptors. And then D dolphin delta receptors or enkephalins. And then kappa kiss or dynorphins. So these are the mnemonic for opioid receptor and their primary ligands. Let's go to the opioid uh, distribution of opioid receptor in the body. Primarily, the major opioid receptors are the mu. Mu receptors are distributed across the body that includes central nervous system and peripheral nervous system and gastrointestinal system. So in the central nervous system, they are found in thalamus, periaqueductal gray, and limbic system. There they regulate pain and also respiratory depression and euphoria. Whereas peripheral nervous system, they modulate pain at the site of injury. Whereas gastrointestinal system mediate opioid side effect, that is one of the major side effects of opioid, that's constipation. Next, delta in the CNS system that has a hallucinogenic effect and also decrease gastric secretions. Kappa is reduced pain signals in the CNS, the site of injury, and then also induces the dysphoria. These are some of the specific actions of these mu, delta, and kappa receptors in central nervous system, peripheral nervous system, and gastrointestinal system. So opioids produce two types of responses. One is the inhibitory response and then activation response. Inhibitory response means opioids, they act on the nociceptor neurons and the neurotransmitters are released like enkephalin, endorphins, dynorphins, and then they bind to those mu receptors and they suppress the pain. So therefore, the mu agonist are the one that are used for pain relief. Like opiates are mu agonists. And then also the inhibitory response of the GI smooth muscles, that means they reduce the gastric motilities and that results into constipation. And then also the inhibitory response in the respiratory system, so therefore they can result into overdose, can result into respiratory depression. And they do affect on inhibitory effect on bladder, uterus, and then activated response or they activate the mast cells. So when you activate the mast cells mean what do you expect? It releases the histamines. So most opioids, they especially IV injection, they release the histamines from the mast cells and often result into allergic symptoms or itchiness, or can result into hypotension. Hypotension side effect comes from those mast effect release of histamines. And then oculomotor nerve and also chemotherapy trigger zone uh, is the site where they activate and therefore they result into nausea, vomiting, and they also have effect on the gallbladder. So let's see what kind of a response the inhibitory response produces, what kind of effect. So inhibitory response produces one on the analgesic effect, constipation, respiratory depression, and urinary retention, which is commonly associated with the inhibitory response of the opioid neurotransmitters. Whereas activation response are in the mast cells, they release mast histamines. Oculomotor nerve can result into miosis because of pupillary constriction, and then gallbladder can result into increase in contraction of gallbladder. So therefore, it can result contraindicated in gallstones. And activation of chemoreceptor trigger zone that can result into nausea, vomiting side effect of opiates. All right, so let's talk about the side effect. Having seen those activatory response and also Inhibitory response, we can talk about the side effect. So here is the mnemonic for side effect. Morphine. M for meiosis. Opiates cause meiosis. O for out of it, sedation. R for respiratory depression. P for pneumonia, especially the risk of aspiration pneumonia. And H for hypotension, it dropped the blood pressure down. And I for infrequency or constipation, infrequency of gastric motility, and then also urinary retention. N for nausea, and E for emesis, nausea and vomiting can trigger by the opiate. All right, so let's look at the more details on these side effects, especially respiratory system. And also there are myocardial infarction, stroke up to 1% possible. So therefore, monitor respiratory rate, oxygen saturation, and sleep apnea in common patient with chronic therapies, screen symptom before during therapies. And the dangerous condition, decreased respiratory drive, high risk with the long acting opiates. So therefore, avoid combining opiate with CNS depression, especially benzodiazepine can result into more risk of respiratory depression. So next, the major side effect, gastrointestinal side effect of opiate, which has no tolerance as well, that is constipation. So all patients who receive a opiate, they should be given stimulant laxatives and stool softener with opiate therapy to minimize the risk of constipation. And also advise patient to increase fiber diet and fluid and physical activity to reduce gastrointestinal side effect, primarily constipation, which comes with the all opiates, and constipation has side effect of no tolerance. I mean, it can as long as patient take the opiate, patient may experience constipation side effect. Nausea, vomiting can have a tolerance after some time, so that means using antiemetic initially is necessary sometimes. Next, gastroesophageal reflux, which is a hard one, so can increase. Some cases can recommend antacid or H2 receptor blocker if you are using long-term use of opiates. CNS side effects include sedation, especially when starting therapy, increase the dose. So it causes the drowsiness. So therefore, reduce the dose or rotate opiate if limits activities. Cognitive impairment can affect daily functioning. So therefore, it is important to monitor those cognitive functions. Dizziness up to 20%. So it can be more risk of falls. To avoid the risk of falls, uh, uh, slow position changes are recommended. Next, opiates also have a serious overdose risk, and opiate overdose risk is very high, especially for those who have a history of overdose or history of substance abuse. More than 90 milligram morphine equivalent daily dose, or those taking benzodiazepine, gabapentin, and pregabalin, which is non-opiate drugs, but combining them with the opiates risk increase the risk of those combinations of those overdose risk. And especially one dose can be fatal in a child, so that require extreme precautions. Opiates also have withdrawal symptom. Someone who's taking chronic opiate for a long period of time, if they suddenly stop using, they can result into withdrawal symptoms. So therefore, opiate have to be gradually stopped. An opiate symptom typically or withdrawal symptom can be chills, sweating, and palpitation, and also can cause other symptoms such as diarrhea, yawning, irritability, runny nose. You might have noticed patients who are on chronic opiate therapy, they may time to time they experience runny nose that could be sign of opioid withdrawal symptoms. So tramadol withdrawal syndrome may also include serotonergic effects because tramadol also have a partially effect on serotonin reuptake inhibitor, therefore that can result into serotonin withdrawal symptom. especially those opiate that has a effect on serotonin reuptake inhibition. Next, there are lots of serious drug and drug interactions, especially drug interactions, serious drug interactions are with the CNS depressants, which can result into sedation, respiratory depression, and in some cases death have occurred. So therefore, avoid alcohol, avoid benzos, antihistamine, gabapentin, pregabalin, or reduce the dose if required with these opiates. MAO inhibitors have to be avoided for 14 days with the opiates, and then also, especially for drugs such as methadone, buprenorphine, that can result into QT prolongation. Drugs with a high QT prolongation require precaution with combining these drugs. So also anticholinergic drugs can cause constipation, which can cause additive risk. Serotonin syndrome possible if combined with antidepressant or MAO inhibitors combined with tramadol can result into serotonin syndrome risk. And also, carbamazepine tramadol combination can increase the risk of seizures because seizure is a side effect of um, tramadol, mean they decrease the seizure threshold. Next one is s- the enzyme interaction with the opioid, especially CYP2D6 and CYP3A4 interaction. And CYP2D6 substrates are codeine, hydrocodone, and tramadol, which are also known as CYP2D6 substrates. So avoid inhibitors such as amiodarone, quinidine, fluoxetine. All those things should be avoided with um, CYP2D6 inhibitor. Avoid with those substrates. And CYP3A4 substrates such as buprenorphine, fentanyl, methadone also require precaution with these CYP3A4 inducers and inhibitors. Both of them require precautions. CYP3A4 inhibitors are phenobarbital, phenytoin, carbamazepine, rifampin. Those are very classical, strong, potent inducers that require precaution. And strong CYP3A4 inhibitors are azole antifungals like ketoconazole, antiviral protease inhibitors, clarithromycin, erythromycin, verapamil, diltiazem. They are known for CYP3A4 inhibition. And here are those drug lab interactions, such as codeine can give you false positive morphine test, and morphine can interfere with this drug screening, and also fentanyl can give you false positive for amphetamine. So these are the few more drugs that are known to interact with the drug and lab interactions. So next, let's talk about the safety of this drug in pregnancy. Pregnancy opiates can cause neonatal opiate withdrawal syndrome if you use prolonged period during pregnancy. So avoid opioid use in third trimester unless absolutely necessary due to risk of fetal dependency. Whereas lactation, weigh the risk versus benefit, infant may develop withdrawal symptoms. Lowest possible dose of codeine may be used. Monitor infant for CNS adverse effects. Breastfeeding, use with caution, short-term use generally safe. Monitor infant sedation, respiratory depression, feeding difficulties. So also a regular monitoring for respiratory rate, oxygen saturation, signs of sedation, cognitive impairment, constipation, blood pressure, heart rate. Those are regularly should be monitored for patients who are taking chronic opiate therapies. And then also known for abuse potential, all opiates, agonists and partial agonists have a potential for abuse and also diversion, criminal diversion. Fentanyl, illicitly manufactured, highly potent fentanyl analogs are particularly concerned. Physical dependency is common with the chronic use. Tolerance with chronic use developed with the opioid-induced analgesia, nausea, sedation. But opioid-induced constipation will remain all the time. So next, the important key points here, pharmacokinetics, metabolism. Morphine is metabolized by glucuronidation. 6-morphine glucuronide is the active part of the morphine metabolite. Codeine has a genetic polymorphism. What that means is codeine is primarily metabolized by CYP2D6. So a patient who have a genetic polymorphism may uh, may not be suitable candidate for codeine. If they are fast metabolizers or slow metabolizers, codeine may not be appropriate for them. However, normal metabolizers of codeine, they could use codeine. And CYP2D6 also necessary for tramadol to become active, and hydrocodone partly metabolized by CYP2D6 to hydromorphone. So meperidine can cause neurotoxicity if it is patient who have renal diseases because it can cause normeperidine metabolite, which can result into CNS toxicities. Here is the medicinal chemistry of opioids. Morphine is a natural opioid structure, which is also known as phenanthrene derivatives. Hydromorphone is a ketone. 3 oxygen here, a hydroxyl group has turned to ketone group, whereas fentanyl is synthetic. All of them has a piperidine ring present in those structures. Well, metabolism of pathways of codeine or codeine is 3-methyl morphine, and this become demethylation and makes the active drug morphine, which is done by CYP2D6 enzyme. So here is a mnemonic for metabolic pathways of codeine. The mnemonic is code C for CYP2D6, O demethylation to morphine, and then O demethylation to morphine, and D for demethylation and methylation to narcodeine by CYP3A4, E for excretion via glucuronidation process. All right, with this information, this is the short, quick, and key point summaries of the opioid. For more drug monographs and their complete reviews, subscribe Pharmacy Prep and also subscribe Asterix Drug Information Reference that provides you all these details and the key points and question and answer for these. Thank you for watching. Stay tuned for more drug classes.